Hello and welcome to today's webinar for mental health professionals, the SPACE program, How Parents Can Help Children Overcome Anxiety, featuring Dr. Ellie Leibowitz and Dr. Yara Shimshoni. I would like to introduce Drs. Leibowitz and Shimshoni. Professor Leibowitz studies and treats childhood and adolescent anxiety at the Yale School of Medicine Child Study Center. His research focuses on the development, neurobiology, and treatment of anxiety and related disorders, with special emphasis on family dynamics and the role of parents in these disorders. Dr. Leibowitz is the lead investigator on multiple funded research projects and is the author of research papers, books, and chapters on childhood and adolescent anxiety. Dr. Yara Shimshoni is a clinical psychologist and associate research scientist at the Yale School of Medicine Child Study Center. As a member of the Anxiety and Mood Disorders Program, directed by Professors Wendy Silverman and Ellie Leibowitz, Dr. Shimshoni conducts research and provides clinical care for anxious children and their parents. She is currently the lead investigator on a pilot study examining the feasibility of a parent-based treatment she developed for child avoidant and restrictive eating. There will now be a brief moment of silence while I pass the presenter role to our presenters.
Great. Well, thank you very much for the introduction, and thank you to ADAA for finding a way to host this this talk. And we're happy to be sharing some of our work with everyone. And so, with that, I think we should probably just jump right in. And the focus of the talk is really on anxiety in children and in adolescents. And the next slide really sets the stage for a lot of what we're going to talk about, because in addition to having a lot of cute pictures, the slide is really trying to make a point about human beings and the way anxiety works in human beings that is really fundamental to understanding anxiety in children in particular, and to the parent-based treatment space that we're going to talk about. The pictures on the slides are all pictures of, if you go back for a second, the pictures on the slides are all pictures of mammals, and specifically of pairs of mommy-child mammals. And the point that the slide is making is really that we, as human beings, fit into this group because we're mammals too. And that has implications for understanding how anxiety works in children, because mammals are born essentially not very well prepared for life. They're not able in infancy and childhood, not really able to fend off threats effectively, and also not the most effective at self-regulation and self-soothing, meaning to calm themselves once the anxiety system has been triggered. And in fact, across mammalian life, including in human beings, young mammals and children respond to fear in a way that is meaningfully different from the way that more mature members of the species, the way adults respond to fear. Because where an adult might respond to fear with a more individual self-defense, fight or flight kind of response, a young person responds to fear in a social way. Babies, children respond to fear not in that entirely individual way, but rather in a social way by alerting their caregivers, by sending out cues, essentially, to their caregiver that they're experiencing a threat or a danger. And so if one were to scare a young child, for example, something we do not recommend doing, but if one were to scare a young child, for example, or a baby, that baby doesn't respond by trying to directly tackle the threat, but rather by sending out these social cues, which can look like crying, can look like facial expressions, a change in skin color, so they might get all red in the face and scrunch up their face and make a really loud cry. And as emphasized on the next slide, it's not only the child who is sort of hardwired to send out these cues of fear or distress, but caregivers, primarily parents, are also hardwired to notice those cues and to step in to provide those crucial functions of protection and of regulation once the threat has been dealt with. And what that means is that anxiety in children is actually inherently an interpersonal phenomenon, a systemic phenomenon that involves signaling by the child and response on the side of the caregiver. And once you think about anxiety in children in this way, it becomes very evident very quickly that parents are in fact deeply involved in their children's anxiety systems, because everything that we just said holds true for the natural, healthy, anxious response, but it also holds true for the chronic and less appropriate activation of the anxiety system that is typical of children with an anxiety disorder. So a child with an anxiety disorder who frequently experiences threat or danger is going to send out that cue and is going to receive from the parent protection, reassurance, regulation. And once you look at it in that way, what you see is a very high level of involvement by parents in the symptoms of their children's anxiety through a process described briefly on the next slide that we often term family accommodation. And what accommodation is really referring to is just all of those different ways in which parents, caregivers, change their own behaviors in order to help their child who's experiencing anxiety to experience it less, to avoid the anxious experience, or to alleviate it once it has been triggered. And so these are just a few common examples of accommodation. For example, a child with generalized anxiety who's chronically worried may ask many repetitive, sometimes seemingly endless reassurance-seeking questions, and parents may accommodate by responding repeatedly and also endlessly to those questions. Or a child with separation anxiety may fear being away from the parents, and parents may accommodate by staying near the child or potentially by sleeping next to the child at night or not leaving the home. Or a child who has more obsessive compulsive symptoms of anxiety may involve their parents in that through parent participation in ritualistic behaviors, or listening to a child's obsessive compulsive confessions, for example. Those are some examples of active participation by parents in symptom-driven behaviors of the child. We also see modifications to the family's routines and schedules. For example, parents coming home earlier from work to be with a child because they're anxious about being alone, or driving special routes, like the parent who doesn't drive over the bridge because the child is scared or afraid of heights, or just sticking to very rigidly ordained schedules and timetables because otherwise it creates higher anxiety in the child. And in fact, as summarized on the next slide, we now have data on accommodation by parents of anxious children from all around the world. There's been numerous studies of this, not only in the United States, but also in many other places in the world, from almost every continent. And what we see are very consistent findings. First of all, we see that accommodation is extremely prevalent. Somewhere between 95 and 100% of parents of anxious children, when asked, endorse engaging in frequent accommodation of their children's anxiety symptoms. But we don't only know that it happens a lot, we also know a few other things about it. One thing we know is that although the accommodations are well-intentioned and are intended to help the child experience less anxiety, they're actually not effective at reducing anxiety over time. So in the immediate, very short term, a child may feel less anxious when they are accommodated. So that child who's worried and gets an answer to their question may feel less worried in the moment. However, over time, higher levels of accommodation are actually consistently linked to higher levels of anxiety in the children and not to lower levels. And they're also linked to greater impairment for the child as well as for the rest of the family, because the accommodation places a significant burden on everyone in the family. It places a burden on the parents, who are sometimes expending significant resources in terms of time, energy, and even money in trying to accommodate their child. It can also place burden and impairment on other siblings in the family. So for example, in a situation where a child has social anxiety and has a sibling who's not allowed to have playdates in the home because the entrance of another person into the home causes that anxious child to feel uncomfortable, and the parents are accommodating by not allowing the playdates to be at home, well, now we have impairment not only for the anxious child and the parents, but also for the siblings as well. And in addition, we know that high levels of accommodation are predictive of worse treatment outcomes for our frontline treatments for anxiety disorders, treatments like cognitive behavioral therapy, or even pharmacological treatments with medications like SSRIs. And finally, noted on this same slide, is the fact that high levels of accommodation are predictive of the accumulation of additional problems. So in one example, a child who has, for example, nightmares and is accommodated because of the distress that those nightmares cause, over time is likely to accumulate additional sleep problems, such as going to sleep later or not sleeping alone in their bed, etc. And so on the next slide here, what we see is one conceptual model for how accommodation can actually maintain or contribute to ongoing high levels of anxiety in the child. What this model is briefly illustrating is how, starting at the top, at 12 o'clock on this cycle, what we can see is that a child is experiencing distress related to their anxiety. So there's some symptom that elicits anxiety in the child, and parents respond by accommodating, and there is some short-term reduction in the child's distress. However, what also occurs is a strengthening of the child's dependence on the parent for regulating their anxiety, and an ongoing belief on the part of the child that they are not able to cope with anxiety on their own, which leads to a maintenance of symptoms, of anxiety symptoms over time, and the cycle perpetuates with more anxiety symptoms and then more accommodation, etc. And going forward from here, it's interesting to think a little bit about how much children are aware of accommodation by their parents. The bulk of research on family accommodation actually focuses on parent ratings. And so I mentioned before, we have data from all over the world, and most of that data comes from asking parents, do you accommodate your child? And there are measurement instruments for measuring accommodation. However, there's also a measurement instrument that asks the children about their child's anxiety. And the first thing I would note is that children are actually fairly good reporters of accommodation that their parents do. And so they're not generally unaware, and there's a decent correlation between the levels of accommodation reported by parents and the levels of accommodation reported by children. Of course, that correlation is not perfect, and the best information is derived from a multi-informant strategy that asks both the parents and the children and integrates the information. However, when asking children about their parents' anxiety, we also ask a few additional questions in order to gain some insight into children's understanding, not just of how much their parents are accommodating, but of the process. And so one of these questions is the first one you see on this slide, which is, do you believe as the child that the accommodations help you in the short term to feel less anxious? And when we look at the children's answers to that question, the summary is, yeah, children do, on average, tend to endorse the idea that when my parents accommodate, I feel less anxious in the moment. But we also ask them, what about over a longer term? Do you think that if your parents continue to accommodate this way, do you think that you will feel less anxious over time? Do you think it'll help you to become less anxious in general? And really interestingly, on average, the children's response to this question is actually no. meaning that children have good insight into the kind of cycle that we were just describing on the previous slide. They understand from their own experience that accommodation over time actually doesn't lead to low levels of anxiety over time. And so the next natural question is, do you think your parents should accommodate less? And here, the answer is a fairly resounding no. And so what we learn from this is that children are quite aware of accommodation. They know that it's not actually a useful strategy over time, but they're also very reluctant to give up those accommodations, which is understandable given how much anxiety they're experiencing and given the fact that they may not believe that they have an alternative way of coping with anxiety. And all of this really leads to the treatment that we want to talk about, which is really summarized here on this slide and is distilled into these two bullets. So the treatment that we're talking about is called SPACE, which stands for Supportive Parenting for Anxious Childhood Emotions. And what you can see on this slide is that you can really boil down everything that goes into SPACE, which is a manualized treatment protocol and an entirely parent-based treatment, meaning that there does not have to be any direct involvement on the part of the child in therapy. The treatment can happen without the child ever actually encountering the therapist, although of course it can also happen alongside more direct child therapy. And these are the two things that we try to help, the two big picture changes that we try to help parents to make in SPACE. The first one is to increase what we would think of as supportive responses to their child's anxiety symptoms. And very soon, we're going to explain exactly what we mean by a supportive response. What's a supportive response to a child's anxiety symptom? But that is one of the two legs that this treatment really stands on. The other big focus of the treatment is on the accommodations that we've just been talking about, and on reducing systematically the accommodations that parents are providing. So those are the two main objectives of treatments, and other components of the treatment are really there to facilitate those two goals and to help tackle some of the common difficulties that parents may encounter in trying to achieve those two goals. So breaking it down into just a little bit more detail, and then I'm going to hand it over to you, Yara, to get into some of this in a little bit more detail. Here you can see the process of treatment laid out in a little bit more detail. And so treatment starts with an introduction to parents, and we'll share a little bit of what it is that we want to actually educate parents about and what information we want them to have in starting this treatment. Then the focus of treatment really becomes around increasing those supportive responses. And then effort is put into mapping out and charting all those different ways in which these particular parents are accommodating the child, the patient. And once that's occurred, a specific target accommodation is selected by the therapist with the parents for reduction, and very detailed, practical, and pragmatic plans are formulated for how that accommodation is going to be reduced. And then those plans are communicated to the child very clearly and very supportively. And then the parents start implementing those plans and actually reducing their accommodation while maintaining those supportive responses. Once a significant reduction has been achieved in the target accommodation in a reliable manner, meaning parents are able to reliably not accommodate in the way they had been previously, an additional target may be taken on, which might be a further reduction of the same kind of accommodation, or it could be taking on another accommodation that wasn't previously targeted. And then at the very last step of this sort of stairway that you can see on the slide are some modules, which we'll also talk about. And what that refers to is really a toolkit for problem-solving challenges that parents run into. And so you'll see some examples of that, but just to sort of preempt a tiny bit. One common challenge may be a child who resists the parent's plan to reduce accommodation, or who becomes very distraught or upset when parents don't accommodate as the child has been accustomed to. And so SPACE includes a toolkit for problem solving and overcoming those challenges while continuing to reduce the accommodation and while continuing to maintain a supportive and loving attitude toward the child.
Okay, so before we go into the description of all those stages that Ellie just briefly introduced, I'd like to introduce a case, a family that I worked with. And as we describe the treatment, we will demonstrate how we apply the different steps for this case. So when I first met Mary and Jay, they described their son Adam as a sweet and quiet 9-year-old boy. Adam was a very good student. He loved to read, and he played baseball in the spring and in the fall. Adam had 2 younger sisters. Molly was 7 and Emily was 4. Parents described Adam as being afraid of many different things. He was afraid of dogs, and specifically the neighbor's dog who would always bark at him. He was afraid of thunderstorms and the chance of a hurricane and getting his flu shot. But mainly, Adam was afraid of being alone. He was very worried that something bad would happen to him if he wasn't with his parents all the time, and he did everything within his power to be next to them always. For example, he avoided being alone in different rooms of the house. He refused to take the bus to school and showed clear signs of distress, often crying and clinging to mom when it was time to enter the building. When parents attempted to go out sometimes and to leave him with a babysitter or a family member, he would cry and beg them not to go. He would then run after them to the car, yelling, accusing them of being bad parents who abandoned their children. After they left, he'd call them repeatedly 10 or 20 times until they'd pick up and demand to know their exact plans. Where are they? What are they doing? And when are they coming back? And of course, he'd stay up and wait for them even when it was very late. Every night at bedtime, Adam needed one of his parents to sit with him until he fell asleep. Now, Adam's anxiety and distress led Mary and Jay, the parents, very naturally to do everything they could so he didn't have to be alone. When he called them, they came. They stayed with him in his room until he finished playing or doing his homework, and delayed other very important activities such as preparing dinner for the family or helping the sisters with their baths. They accompanied him to different rooms of the house, including when he went to the bathroom, and they allowed him to accompany them, including to the bathroom. They announced themselves around the house so he'd know exactly where they are all the time. Mary drove Adam to school every morning, causing her to be constantly late to her job. And eventually she had to cut down her work hours, and this had a financial impact on the family as well. And one of the parents would sit next to him every night until he fell asleep. So this is 30, 45 minutes of doing nothing else, leaving very little time for parents to be together after this. And finally, all the yelling and screaming when they tried to leave the house led them to stop going out together as a couple. So they would go separately, but not together anymore. Adam's anxiety also highly impacted his sisters. Parents limited their play dates and after-school activities because they had to accompany Adam to all of his activities. And Mary noticed that she often refuses when the girls want to play with her because Adam needs her. Responding positively to Adam's anxiety was not a simple task for these parents. Most of the time, Mary tried to comfort Adam by explaining to him again and again that really nothing bad is going to happen to him if he's not with them all the time. She hoped that if she explained enough times, or maybe if she just found the right words, Adam would finally understand and stop being anxious. He's really smart. He could get it. But over time, it became clear that all these explanations and the accommodations didn't really reduce Adam's anxiety. Quite the opposite. It seems that his anxiety was growing, expanding. It was affecting more and more situations and taking up more and more of the parents' time. And finally, parents decided to seek help after an incident with Adam that led them to miss Emily's dance recital. So that was Marion J. and Adam, and we will continue to check in with them as we move through the treatment. The first step is the introduction. And what we'd like to do here mainly is to lay the groundwork for the sessions to come. And there are a few issues and topics that we would like to talk about openly with parents here. Maybe the first one could be that parents are the ones that are coming to treatment, but SPACE is actually a treatment for their child's anxiety. So we want to clarify that this is not the parents' therapy, this is not couples therapy, this is the actual treatment for the child's anxiety, and that will be the focus of our discussions and treatment. And this could raise the question, well, if this is a treatment for child anxiety, why are we here, the parents? And we recommend talking about this openly and explicitly. And here we incorporate some of the issues that Ellie brought up in his introduction to this webinar. For example, we talk about the systemic nature of anxiety and how parents are inherently and inevitably involved in the child's anxiety symptoms. So it does make sense to work with them on this. Another important issue is that parents in SPACE accept the premise that when it comes down to it, we really cannot control another person's behavior, and parents can't make their child face their fears. But this does not mean that parents are helpless in helping their child with their anxiety, because parents still have a very powerful tool in their hands, and that is their control over their own behavior. And this is going to be the focus of SPACE and of our sessions. So we will never send parents home and ask them to try to directly change their child's behavior. Why? Because this will probably lead to frustration, conflict, escalation, and probably not to less anxiety. We will only be asking them to change their own behavior. Now, participating in a parent-based treatment can be stressful to parents. It's easy to feel blamed. It's easy to feel inadequate as a parent and defensive when we talk. So we want to be curious about how parents feel about participating in a parent-based treatment, and to very powerfully convey our message that helping the child with their problem is not equivalent to having caused that problem. And actually, decades of research on child anxiety and parenting has failed to make a very compelling case that parents have caused anxiety. And this is also something that can be important to discuss in the introduction. We also want to discuss the treatment setting and expectations. SPACE is a short-term treatment, usually somewhere between 10 to 16 sessions. And it is also a very active treatment, so parents will actually be asked to do things between the sessions. And coming to the sessions alone, even reaching very insightful understandings about the child's anxiety, in our view, is not enough to make significant change. And some of the things that parents will be asked to do is to take unilateral steps, meaning not everything they do will receive the child's approval and acceptance. And we do this as parents because we think that some things are important for our children. A good example of that could be taking our child to get a flu shot or a vaccination. Most kids are not enthusiastic about going to the doctors to get a flu shot, but most parents feel that this is important and they take them anyway. We want to prepare parents that as we start to reduce accommodations, children may not feel very pleased and not be very thankful. They may be more thankful along the way, but maybe not at the beginning. And we want to prepare them to see a short-term increase in the child's anxiety because we are taking away an accommodation that the child has learned to rely on for regulation for some time. We also want to convey that SPACE is transparent in the sense that we will inform the child about the changes that we will be making. Nothing is done in secret behind their back. We're not trying to trick the child. It's very open and clear. Other aspects of the introduction are we want to learn about how the anxiety is blurring the boundaries between the parents and the child in this family. And anxiety does that in several ways. For example, anxiety can blur the physical boundaries between parents and children. This is very clear in separation anxiety. You can see in the case of Adam how parents were with him physically almost all of the time. Anxiety can also blur the boundaries of time. Parents are very much involved in spending a lot of their time dealing with the child's anxiety. It becomes unclear what is my time and the child's time. Anxiety can also blur emotional boundaries between parents and children. Maybe the last thing that's important in the introduction is to explain accommodation and support, the two main constructs and aims of this treatment. Okay. The next step is increasing support. What do we mean by support in space? Parents support an anxious child when they continuously convey messages that combine acceptance and validation of the child's anxiety and fear with a vote of confidence in the child's ability to handle their fears and be okay. Acceptance means that I acknowledge that my child is truly anxious, that they can't just decide not to be because I don't think they should be afraid of this, or I wish they weren't anxious, and that some things are genuinely hard for them, even though they may not be hard for me or my other children. And confidence means that I show my child that I believe that they are strong and they can handle their anxiety and be okay. And so when we combine acceptance and validation, we get supportive responses. We encourage parents to frame supportive statements and to practice these. An example could be, I see that this is hard for you. That's the acceptance piece. And I am 100% sure that you can handle it, the confidence piece. Why do we think it's so important to support an anxious child in this way? Well, a child who is anxious today is more sensitive to experiencing anxiety later on in life. And so it's crucial that that child believes about themselves that they can handle their anxiety. And this would probably be true for any problem or vulnerability that a child may have. It is so important that they feel like they can handle that problem. And so the goal of space is not that the child will never feel anxious. That is an unattainable goal for any person, especially an anxious child. But rather we think and hope that at the end of space, children feel about themselves that, yeah, sometimes I get anxious in that situation or this situation, but that's okay because I can handle it. And children will start to think about themselves in this way when parents start to look at them in this way. And this is true because parents are the mirror that children look into to see who they are. And if what they see reflecting back at them is, you're too weak, you can't handle this, life is too much for you, then that's what they're going to think about themselves. And sometimes on top of that, they also see the parents' own anxiety about the child's problem and helplessness. And then they also think, my problem is so big that even my parents don't know what to do. And so one of the greatest gifts that parents can give an anxious child is a reflection of someone who can handle their anxiety, someone who can take their anxiety with stride, someone who doesn't have to be afraid of feeling anxious. And this will help children to suffer less from their anxiety, and they will be more willing to experience it. And we know that when somebody is willing to experience anxiety, they are already on the way to getting better. We'd like to share with you a short video of one of our therapists explaining support to parents.
Dr. Shimshoni, I'm going to interrupt for 1 minute. It doesn't sound like the volume is working on your video.
Okay, so I'll just continue. Okay. Maybe to summarize, one way that we found is very helpful for remembering what we mean by support is to think of support as a recipe from a cookbook, a very simple recipe. It only has 2 ingredients, but you really need both ingredients to make support. An example could be an all-time favorite, mac and cheese. It's pretty simple, but you really need mac and cheese to make mac and cheese. So if you're only providing validation, acceptance, that's great that your child is hearing that you understand them, but you're making mac and mac. If you're only providing confidence, it's also great that your child feels that you think that they can handle things, but you're making mac and cheese. So we really want both of these components when we try to be supportive. And we help parents in treatment to formulate some supportive statements that fit their beliefs, their family, their child. In the case of Mary and Jay, this is the statement that we came up with. We know you get scared when we don't come with you to get things from your room. That is the validation piece, but we're sure that you'll be okay. Okay, sorry, that is the confidence. So at this point in treatment, we've gone through the introduction. Parents understand the background, the theoretical premises. They know what accommodation is. They understand the impact of accommodation on their child's anxiety. They know what we mean by support, and maybe they've also practiced supportive statements for a while. And this is a good point to pause and ask parents, where do you think you stand on these 2 concepts of accommodation and support? We can use this grid to help visualize this. Most parents at the beginning of the space place themselves somewhere in the red square. And this is what Mary and Jay did. You can see where they put themselves. So Mary placed herself high on accommodation. She felt that she was extensively accommodating Adam's anxiety in almost every way, every day, and many times a day. She also felt that she was pretty good at validating his anxiety. She really got it, she understood, so she put herself higher on support. Jay, on the other hand, felt that he was accommodating a little less. There were a few things that he was not involved in, and he also realized that he was not at all being supportive in the sense that we meant. He was not validating, and he was not providing confidence. We could also use this grid to visualize the process that we're trying to work on in space. And we can show parents that we'd like to move towards the green square. So at the end of treatment, we hope that parents will be lower on accommodation and higher on support. But space doesn't stop here. We don't teach parents about accommodation and support, and that's it. We also want to provide them with practical tools and guidelines on how to translate these theoretical understandings to practical things that they can do to help reduce their child's anxiety. And that is going to be what we do in the next sessions.
So at this point, parents are hopefully going home and practicing making a lot of supportive statements, and our focus can shift to now include more emphasis on the actual accommodations. And the first thing that we'll want to do is really create a very detailed map of all the ways that parents are accommodating this particular child. And this is one way that you might do that, is by really going through the entire day. And we can start that day as early as is relevant, maybe as soon as parents wake up. If for some parents, it might be that they're waking up earlier than they otherwise would because of the need to accommodate a child. So we'll start from the morning and go through the entire day, getting dressed, meal times, getting to school, the time the child's in school, coming home. These are all pre-COVID-19. For those who don't remember what going to school is, it's an outdated tradition where children are actually transported from their home in the morning and relocated temporarily to another building full of other children. And so this used to happen, believe it or not. And during that time, there may be accommodations that are happening while the child's in school. In some cases, a parent is staying in the school building because otherwise the child is too anxious to attend. In some cases, they're answering phone calls from the child or the nurse during the time the child's in school, and then getting back home. Yara mentioned in the case that she described a child who was being driven to and from school instead of riding the school bus. Doing homework can entail any number of accommodations. And again, meal times, getting ready for bed, going to bed, of course, can entail tremendous accommodations, and throughout the night there may be accommodations. And so we're going to go through the whole day like this, and we're going to do that for each of the parents of this particular child. And we'll also want to do it separately, thinking about regular days, like days, work days, as well as weekends, which might look different and have their own accommodations. And we'll also take an interest in accommodation by siblings, although we probably won't be choosing to focus on a sibling accommodation as the focus of accommodation reduction plans. I think on the next slide, you can actually see an example of the accommodations that Adam was being provided by his parents, and I'm not going to read all of them individually, but you see there's a lot of examples for each part of the day, like picking up from school, accompanying to the bathroom, going to sleep in Adam's bed at night, going upstairs with him when he has to go upstairs, making sure they're always with him, etc. And we're asking parents to come up with essentially a tally of how frequently they're doing each of these behaviors, because that will also help us in making a good choice for where we should focus. And so we'll come up with a map just like this one. And once we think we have a good understanding, maybe not a perfect understanding, but a good understanding of the accommodations that parents are providing, we're going to ask them to monitor their behavior throughout the week at home so that they notice, now that they've thought it through so much, they may notice additional accommodations that hadn't come to mind, or they may realize that the tally that they had given based on memory was actually a little bit off. And once we have that, we can then begin the process of actually choosing a particular accommodation for to reduce, which brings us to the next step, really, of picking a specific target. And these are some criteria to think about when we're considering what might be a good target to reduce in treatment. Saying it really briefly, we want to pick a problem that's a meaningful problem, that interferes with family life, that feels burdensome to the parents, and that's so that change will be meaningful to them and so that they'll be motivated to actually stick with a plan, especially if it proves to be a little bit challenging or difficult. We want an accommodation that happens frequently so that they have ample time to practice and ample opportunities to implement their plan. We want to make sure that the target accommodation that we're focusing on really is related to the child's anxiety and is not reflective of some other problem or difficulty, perhaps a behavioral problem or something else that may be leading to a problematic behavior, but that is not actually anxiety related. We want to take into account the parent's own motivation. What would be useful for them? What do they think would be a good accommodation to reduce? And of course, it goes without saying, but we listed it anyway, it should be an accommodation. And what we mean by that is to really take a look and make sure that the way we're framing our target really is an accommodation that parents do. Because it's very easy to slip back into thinking more about the child's behavior than about the parent's behavior. So for example, you might ask a parent, what is an accommodation you'd like to reduce? And they may say, well, he calls us many times during the day on the phone. And the child calling is a symptom of their anxiety, no doubt, but it's not actually an accommodation on the part of the parent. On the other hand, me as the parent answering those phone calls and responding to my child would be an accommodation and could potentially be a good target to focus on.
So to check in with Mary and Jay again, we can see their map, and highlighted in yellow are options that came up while discussing this accommodation chart in treatment. And the process that we went through for choosing the accommodation was to discuss each of these highlighted possible accommodations to see which one was the best one to target first. So very briefly, you can see the first one is mom drives Adam to school. This was really a problem for mom. As you remember, she was constantly late for work. She had to cut down her work hours, and she would really love not to do that and for him to take the bus. After discussing, parents felt that this would be, the mornings were too stressful in their house. They had 3 children to get out of the house. They had to get to work, and they felt that they didn't have the resources to start with this target. The second one is mom stays in eyesight at baseball practice. Sounds like a good one. You can see the frequency was twice a week, which isn't very high. Still, we could do that. The reason we didn't choose that target was that baseball season was approaching an end, and so they wouldn't actually have a lot of opportunity to practice this. I'm skipping the evening for a minute, moving down to mom or dad laying in bed with Adam until he falls asleep. Jay's dad was especially motivated to work on this. He really wanted some time in the evening to himself or to spend time with Mary. And in discussing this in treatment, it turned out that Mary's motivation wasn't very high. She actually was ambivalent about this because she really enjoyed this time snuggling with Adam and talking with him at the end of the day. So we didn't choose that one because her motivation wasn't so high. We can see that in the evening hours after school in the house, there are a few things kind of lumped together. Eventually, these were the ones that we chose. Parents accompany Adam to different rooms of the house and to the bathroom. They felt that they could do things in the house, that the frequency was high, and these were the chosen targets. And we translated these accommodations into a specific target, which was not accompanying Adam to different rooms. And this included that they close the door when they go to the bathroom and that they would not announce themselves when they walk around the house. Those were the targets for this treatment.
So having selected a target, our next objective is to create a detailed plan for what parents are going to be doing differently, for how they're going to actually reduce those accommodations. And we want that plan to be as detailed and specific as possible. So simply saying to parents, don't accommodate is obviously not actually an effective strategy, much like saying to a child, don't avoid things you fear is not really equivalent to doing cognitive behavioral therapy because they need much more specific, detailed steps. But even once we've chosen a particular target, we want to get more detailed than simply saying, don't do that anymore. And so we'll think through with parents, what exactly are they going to do differently? When are they going to make those changes? Is it every day? Is it some of the day? Is it part of the day? Maybe only the morning or only the evening? And there can be a lot of different considerations for why you might choose to focus on one part of the time and not another. We want to talk through who is going to be making those changes. Is it only mom? Is it two parents, etc.? What are parents going to do instead? We want parents to go into those situations with a clear understanding of what it is they are going to do. Sometimes that can be as simple as what I will do instead is nothing. I will walk away. I will go to my room. I'll put on some music to help myself distract myself. Sometimes it will be I will make a supportive statement to my child, and then maybe I will walk away. Sometimes it will be something else, but thinking it through means that parents don't have to improvise in the moment and will be much more able to stick to the plan. We want to think through how much, how many times. Is it a complete reduction? Are we not going to do that accommodation at all? Or are we only going to do it a certain amount, or maybe how many times or how much of the time, etc. And I already alluded to this a little before, but we're going to, at this point, start stress testing this plan by asking parents, what is going to make it hard? How might your child respond in a way that would make it difficult? Or what other things might make it difficult? And we want to problem solve those things as well, so that parents are as well equipped as possible for actually coping effectively with implementation of their plan. And we make use of people from outside the immediate nuclear family who might be able to help in this process. Sometimes having an aunt or an uncle in the house when we're putting our plan into place. Sometimes having somebody on the phone with the child or with the parent to help get through those situations. So we really want to make sure we've thought through this plan in as detailed and specific a way as possible, and to write it out so that we all agree and know what it is that's expected of us in the coming week.
So this is Mary and Jay's plan to illustrate that point. We will not announce ourselves around the house. If Adam yells for us, we will not yell back. We will not accompany Adam to different rooms of the house, including to the bathroom, right? And we will close the door to our bathroom. If Adam is showing signs of distress, we will say a supportive statement and try to disengage. This has to do with what we're going to do instead. And when are we going to do these things? We will do these things in the hours after school and during the weekends at home. So we can see that this is a pretty detailed plan that answers most of the points about what a plan should entail.
And having made that plan, parents are almost ready to start implementing it. But there's one thing they still have to do first, which is to let the child know what is coming. There's no benefit to surprising an anxious child with changes. Those don't tend to make the process any easier. And so we want to let the child know in advance. And we will help the parents by actually writing out a written message from them to their child explaining what it is they intend to do and why. And we want to craft that message with them so that we can make sure that it remains a focused, brief, and supportive message to the child. There's many ways that a child could interpret a parent's change in behavior. A child might see parents accommodating less and understand that to mean that parents are fed up with the accommodation, for example. Or they may see it as a lack of caring if no framework is given to them for understanding what parents are doing differently. And so we're going to craft a message to the child, and you'll see an example of this momentarily. We're going to craft a message to the child and deliver that to the child in a calm, supportive, and positive atmosphere before starting the plan, and then parents will be ready to actually begin the process of implementing their plan and putting it into action. So I already touched on some of these points already, but we can think through really briefly the format and the content of the message. We do prefer to use a written message. It really helps parents to stay on track with what it is they wanted to say. And it also means that the parents can actually give to the child a copy of the message for them to read again later. We want to do it at a low stress time, so not when the child is at their most anxious. We prefer to have both parents there, and we want to role play this with the parents to make sure that they're able to communicate their message in a calm and supportive way and not in a aggressive manner or a threatening manner. And thinking about the content of the message on the next slide. Okay. I think I've already pretty much said all of these. We do want to keep it brief. This is not the opportunity to write a long novel to your child. We want to make sure it meets that criterion of support, meaning that it's both accepting of the child's genuine difficulty and conveys confidence in their ability to tolerate distress. We want it to be specific so that they actually have a good understanding of what it is parents are planning to do. And we want to make sure that we keep the focus of the message on the parents. This is not about what we expect from the child. It's not a message of you need to do this or you have to get a grip or start behaving differently. It's entirely about what we understand about your anxiety and what we intend to do in order to help you.
Okay, so here is the announcement, the letter that Mary and Jay worked on in treatment and read to Adam once they were done. Dear Adam, we love you so much and are very proud of the way that you have been handling everything this past year. We also see that sometimes it's hard for you when you're not very close to us. We now realize that our behavior so far, for instance, staying close to you all the time, is not helping you at all. We think it's actually making things worse because we are not giving you the chance to see that you actually can be alone sometimes. That is why we have decided that from now on, when we are at home, we will not try to stay close to you and will not announce where we are. We promise that we will not leave the house without telling you. We will also not accompany you to the bathroom and will close the door when we go. This might sound hard at first, but we are sure that you can handle it. We are not angry at you and not trying to punish you. We simply care too much to allow your worries to hurt you in this way. We are always here to help you, but our help cannot be by giving in to your fears. Love, Mom and Dad. So we can see that they started off with a warm and loving statement. The next paragraph is them kind of taking responsibility for their part in the child's anxiety. Then they go on to being very specific about the changes that they're going to make. And you can see that they're saying, we decided, we are going to, we promise, we will also. So it's focused on them. And they finish with a lot of support and love. So we think this is a very clear and good example for an announcement like this.
So that was clearly a positive message from the parents to their child, but that does not always guarantee that a child will receive the message in a positive way. It will probably shock nobody that not all children respond to these announcements with immediate appreciation or gratitude. Some children may become upset. They may cry or get distressed. Some children try to ignore the message that the parents are trying to give them, or to argue with it, or might engage in what we think of as a form of emotional blackmail, where a child says, you don't love me if you say that to me, or if you plan to do that. And so in SPACE, we will prepare parents for coping supportively with the range of responses to the announcement that they might encounter. And the real goal here is for the parents to deliver the message to the child in a supportive way, and then to really end the interaction so that it doesn't evolve into an argument between the parents and children. Having said their message, really the goal is to sort of leave that situation and then focus on implementation. And it really illustrates the power of what Yara emphasized earlier on in this in the webinar about how important it is to really help parents focus on those things that they can control. By making an announcement that's entirely about their own behavior, it means that they really don't need to persuade or convince their child to agree in order to move forward with implementation. Whereas if their message was all about what the child is going to do, then it seems likely that it would be hard for them to end the interaction until they had some kind of compliance or agreement on the part of the child. Because the focus is entirely on their own accommodations and what they're going to do, that's really not necessary, and they can deliver the announcement in a supportive way and then just focus on changing the actual behavior. And so going forward now, I think the focus here is really on implementation. So parents will be implementing their plan, they'll come back to the next session, they'll review with the therapist what went well, what did not go well, when are the times they were able to do it, when were they not able to, or when did they forget, what were some of the challenges they encountered, and how to problem solve and troubleshoot those difficulties so that they can go home for another week and focus on doing it again until they're really able to achieve that level of reduction in their child's anxiety. And so on the next slide, you can see that here we're really focused a lot on monitoring the behavior. We want parents to actually keep track. They can do that in writing, they can use their phone to take notes, they can do it however they like, but we really want to have that data so that we can know when is it going well and when is it not. We make a lot of use of praise. As therapists, we want to praise the parents for the efforts that they're making in implementing the plan. And we know that it's a challenging thing that we're asking. And as parents, we want them to be praising the child for coping. And here, just to make it clear, we're not even praising the child for doing something in particular. We're simply praising them for getting through, for coping with the change that the parent made. And it's really it's almost like a superpower of SPACE that you can guarantee your child's success if you stick to the plan, because all they need to do is get through it and survive. And so even if they did that with a lot of difficulty, parents can still praise them for having gotten through it. And then we just want to be thoughtful about the pace of progress. We don't want to rush forward until that reduction in accommodation has been somewhat reliably achieved. And at that point, we can introduce that next target. I think on the next slide, I think you can see one example of a worksheet that they might use for simply monitoring how it's going. When were the times that they tried to implement their plan? What was happening? How hard was it? Did it go well? And many parents will use a worksheet like this, and others will track it in other ways. The important thing is just getting that information so that we can be thoughtfully guiding the process. And really the other components of SPACE are all about troubleshooting, because we know that there are challenges that parents may run into. And I think on the next slide, you can see some of the modules that SPACE includes for coping effectively and supportively with challenges that occur. And so, for example, some children may become physically or verbally disruptive when their parents are not accommodating. This can make it much harder for parents to stick with their plan. And it can even be harder for a parent of a child who generally is not particularly aggressive, because they may feel somewhat bewildered or overwhelmed by seeing these reactions in their child, and maybe a sense that things are getting worse rather than getting better. And so we have a set of tools for coping with those challenging behaviors on the part of the child. Or another child may make a threat to themselves, a threat of self-harm, such as saying, I will kill myself, or I don't want to go on living if you're not going to help me in the ways that you used to help me, or if you don't accommodate, or if you do this thing that you know is hard for me. And that can be extremely paralyzing for parents, because nobody wants to take a risk when it comes to the child's safety. And of course, we as a therapist definitely do not either. But what we have learned is that we can actually cope with those situations and focus on maintaining the child's safety while also continuing the process of reducing accommodation, as long as we disentangle those two goals, as long as we split apart the idea of reducing accommodation from the idea of maintaining a child's safety. And so there are tools in space for helping parents to navigate those really challenging situations. Or another situation that occurs not infrequently is that parents have difficulty working together, the two of them, in a collaborative, harmonious way. This will probably also not surprise anybody. Not all parents who come to space are necessarily coming with the best working relationship. Sometimes there is blame going back and forth between them, or criticism or frustration. Sometimes there are unrelated marital stressors that might make it harder for parents, or they might have different attitudes about their child's anxiety and different attitudes about parenting. And so we have a set of tools for coping with those difficulties as well, and for improving that working relationship. It's not couples therapy. The goal is not to fix everything about the relationship, but simply to achieve a working alliance that allows the two parents to agree on a plan and then to work together and communicate with each other sufficiently for implementing it at home. And I think that is in as small of a nutshell as possible in a webinar like this, which obviously cannot take the place of a full training on space, but hopefully enough to give the audience a sense of what it is that goes into doing space with parents. And what we'd like to do at this point is share a little bit of information about the efficacy of the treatment. What do we know about the extent to which space works? Well, we started out, as usually happens for a new treatment, and this is going back several years now, we started out by conducting several small open trials and case studies of space in order to test its feasibility and acceptability, and to get some preliminary indications of how efficacious it might be at actually treating anxiety or obsessive compulsive disorder in children. The outcomes of those open trials were very promising and encouraging in that they did show that parents would do the treatment, they would come back, they rated it as being highly satisfactory, and they also indicated that their children were improved. However, as clinical scientists, we know that open trials without randomization and a controlled comparison condition are not really the strongest evidence of efficacy, and that in order to get better indications of efficacy, what you actually want to have is a randomized controlled trial. And so last year, we published the results of a sizable, fairly large randomized controlled trial, which included over 120 children with primary anxiety disorders who were randomly allocated to receive either cognitive behavioral therapy or space. And so children who were randomly assigned to receive cognitive behavioral therapy had 12 weeks of direct therapist-child CBT. And children who were randomly assigned to space did not meet with their therapist at all, but their parents had 12 weeks of space. And what we saw was that the two treatments were actually very similar in outcome. The outcomes for cognitive behavioral therapy and for space were actually very similar, and that CBT was not superior to space. And so one might conclude from that that space is as good as CBT. However, what we also know is that saying that cognitive behavioral therapy is not more effective than space is not quite the same as saying that space is as effective as CBT. Those two things sound synonymous, but they're actually not quite the same, because when you ask the question, is CBT superior to space, what you are really asking is, can I determine with 95% confidence that CBT is superior. When you say space is not inferior, what you actually have to ask is, can I prove with 95% confidence that it is not inferior, as opposed to only not being able to show that CBT was superior? If that sounds confusing, forgive us, but it actually is a meaningful distinction. And so the way to answer the question, was space actually equivalent or non-inferior to CBT, is to do what is called non-inferiority research, which is what we did. And the way that works is like this. You can imagine laid out on the grid in front of you, on that arrow in front of you, imagine the actual mean differences in outcomes between space and CBT. So if the actual difference was 0, it would be marked in the middle of that line. And then if you click one more time, if the outcomes favored CBT, then the actual difference would move toward the blue. And if they favored space, they would move toward the green on the left. Then what you do is determine what is known as a margin of non-inferiority. And that is reflected here on the screen in the red line. So the red line is the margin of non-inferiority. It's the answer to the question, how much worse is actually meaningful? How much worse is worse? Because scales are not perfect. And so a 1-point difference, for example, on a scale is probably not very meaningful. And on another scale, it might be meaningful because it's a smaller range. And so for each scale, what you determine is this margin of non-inferiority based on clinical and statistical considerations. Here, what we're looking at is data for the Pediatric Anxiety Rating Scale, or the PARS. And so for this scale, as you can see in the red, what was determined is that 6-point difference would be considered a meaningful difference. Now, the little arrow, the little upside down arrow is the actual difference. You can see it's positioned at about -1, so very close to identical outcomes for space and CBT, and actually just a tiny bit shifted toward favoring space. And you can see that it is below the margin of non-inferiority. But more importantly, if we draw 95% confidence intervals around that arrow, the two black vertical bars on the slide are the margins of non-inferiority around, are the 95% confidence interval around that difference. What you can now see is that even the right edge of the right-hand vertical bar is still below the red line. And that is what actually demonstrates with 95% confidence that space was non-inferior to CBT and led to our publication in the Journal of the American Academy of Child and Adolescent Psychiatry of a paper entitled Parent-Based Treatment is Non-Inferior to Cognitive Behavioral Therapy for Childhood Anxiety. And I think on the next slide, you can see here essentially the same thing, but now looking at parent-rated outcomes. And on the next slide, you can see it once again, but for child-rated outcomes. And this is maybe the most remarkable one of the three, because what you have to remember is that here we're comparing ratings that were provided by children who had 12 weeks of very good CBT with a therapist to ratings provided by children who actually never met a therapist at all in the course of the study and only met an independent evaluator who assessed their symptoms but had no direct therapist contact. And yet even comparing those ratings, we see the space outcomes to be non-inferior to cognitive behavioral therapy. And we think that is actually quite exciting. And so at this point, we're continuing to do research in space, and we have ongoing additional clinical trial research, but we're also trying to learn more about the underlying neurobiology that's implicated in these in the processes of accommodation in child anxiety, and also in terms of what actually changes neurologically when we do this treatment. And so to summarize this slide briefly, this is actually an attempt to learn about the underlying brain circuitry that drives children to rely so much on their parents' accommodation, or you might think of it as a neurological marker of parental accommodation. And so what we do here is we make use of an imaging procedure of fMRI, or functional magnetic resonance imaging, which is essentially a form of brain scanning. What we do is we have a child lie in a scanner, and they see pictures in the scanner, and those pictures are of faces, and some of those faces are calm and neutral, and other faces are more angry. And we know from previous research that anxious children will show reactivity in fear regions of the brain to the angry faces. And that in and of itself is not quite so novel because it's been demonstrated before. What we did is to repeat that procedure, but to do it twice with each child. Once, the way it's always done, when the child is alone in the scanner looking at the pictures. But then to also repeat it another time when the child is in the scanner, but the mother of the child is right there next to them and holding their hand. And what's of interest here is the degree to which the parent's proximity, the parent being there and holding their hand, influences the child's response to the scary, angry faces. And I think on the next slide, you can see a summary of this. So there's really 2 points to make. One is that when children are alone in the scanner, their brain is responding more fearfully to the angry faces than when their parent is there. And so the parent's proximity is actually having an anxiety regulating effect, which is quite fascinating. What's potentially even more fascinating and demonstrated here in this graph is that if we chart the magnitude of how big of an impact did the parent being there have on the child's brain, what we see is that that impact is directly correlated with the level of accommodation that's reported by the family. In other words, children who have higher levels of accommodation, or whose parents accommodate more, or perhaps who rely more heavily on accommodation, are also the children whose brain is showing the most impact of having mom standing there when I'm in the scanner looking at the faces. And so you can think of this as this neurobiological biomarker of this dependence on parents for anxiety regulation. And in our current clinical trial of SPACE, we're actually using this procedure of scanning these children twice like that, with the parent and without, and doing that both before and after treatment. And although a little too early to share these data with you in terms of slides, what we actually see is a change in that marker of parental regulation of child anxiety as the parents do SPACE. In other words, children have more dependence on the parent for anxiety regulation before SPACE than they do after, which we think is really fascinating and gets at some of the underlying mechanisms for how fear is being regulated, but also for how this treatment is actually working. And I'll just say really briefly here that another biological system that we've been very interested in is the oxytocinergic system. And oxytocin has become very famous as a hormone and a neurotransmitter involved in close interpersonal behavior, in love and attachment and affiliation. And that's why people sometimes get tattoos of the oxytocin molecule shape, or they get jewelry or necklaces and whatever that are all shaped like oxytocin, and why you can even buy oxytocin on Amazon, although to be clear, we're absolutely not recommending doing that. But less famously, oxytocin is implicated not only in close interpersonal behavior, but also in anxiety regulation. And actually, it makes sense that we would have a biological system that straddles anxiety regulation and close interpersonal behavior, because we've been describing anxiety in our species, at least in children, as a social process. And so we've been studying oxytocin in the saliva of children with anxiety problems and their mothers, and seeing very significant links between salivary oxytocin levels and not only levels of anxiety, but levels of accommodation as well. And so we think this is another part of the neurobiological infrastructure that drives the processes and the patterns of entanglement between parents and children that are the target of SPACE. And so I think we will skip trying to show another video, and what we will do is thank the many collaborators and both the mentors, collaborators, students, and all who have contributed and continue to contribute to this work. We want to thank everyone in the audience for listening and attending, and for anyone interested in learning more about SPACE treatment, potentially participating in a more in-depth training workshop to actually learn how to deliver it in more detail. The website on the current slide is the sort of online home for SPACE and the place to go. If you go there, you can find information about training workshops. You can register your email to be alerted when a workshop is scheduled. And we're actually currently holding online training workshops for obvious reasons. And there's also a forum that for parents and another for professionals to participate in, and other resources relating to SPACE, as well as a list of trained SPACE providers which is particularly useful for families who are seeking to get this help for their own children. So with that, again, I think we want to thank each and every one of you very much. And thank you again to ADAA for hosting and facilitating this webinar.
Thank you.
Thank you very much, Drs. Leibowitz and Shimshoni.
Thank you.
For those of you who purchased CE/CME credits, you should have received an evaluation link in your registration confirmation email. You must complete the webinar survey and post test questions to receive a CE/CME certificate. Please email us at webinars@adaa.org if you haven't received this link. If you are not yet an ADAA member, we invite you to view the many membership benefits that ADAA has to offer. ADAA members enjoy year-long access to continuing education programs, free access to special interest groups, including online peer consultation groups, promotion of your practice in ADAA's online Find a Therapist database, significant discounts to ADAA's annual conference, and much more. We would also like to invite you to check out more ADAA on-demand webinars by visiting adaa.org. On behalf of ADAA and our presenters, we thank you for joining us today.